Am I audible at the venue?
Yes, yes, you are very audible.
Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. As has been image taken, right, so we are ready with the case. This is going to be a demonstration of phacoemulsification, of course, but with a trifocal hydrophobic preloaded implant, which comes with the brand name of Geometric from the house of Hoya Surgicals. That will be the highlighting feature of the surgery, but that comes a little later while we finish off the initial procedures. So this is the way I make my tunnels, both of them together, the side port and the main port. 2.2 millimeter incision is the main port, 0.9 is the side port, and I prefer to make all three ports at the same time before I proceed to the next step, which is injecting a very small quantity of preservative-free lignocaine, just to make the patient comfortable right throughout the procedure. Please let me know if the eye shifts from focus and I need to rearrange the focus or anything. Look straight, sir. For viscoelastic, I would be using HPMC alone, no other viscoelastic. The technological difference in the designing of the IL that Naren just implanted, which was the Panoptics, and the Geometric would be something we would be discussing. Look straight, sir. Can somebody help me with the language, please? Can you ask him? So to start with, that would have a 4.5 millimeters diffractive ring, whereas the Geometric has a 3.25 millimeters refractive ring. And the ad bars are almost similar. The light distribution is a little different here. It's much more customized with the Geometric family than it is with the Pan. And it's very interesting to study. The IL that I'll be implanting is the Geometric Plus. So there are two versions of the Geometric and the Geometric Plus. The ad bar remaining the same. It's the light distribution that varies, which is a very, very interesting concept to study. And in fact, it has helped us a lot in customizing the need of the patient and thereby deciding whether we are going for a combination, a mix and match of Geometric and Geometric Plus in the two eyes. Look straight, sir. Geometric Plus in the two eyes, or Geometric in both eyes, or a Geometric Plus in both eyes too. So it gives us a lot of flexibility as far as that is concerned. Check for the mobility of the nucleus a little bit. Softish, grade 2ish. Look straight, sir. Please ask him not to move. I think we can completely understand the fact that the patients have been waiting since morning. So they're likely to lose their patience a little bit. Phaco handpiece, please. Just before we begin, just a short look at the parameters that I would be using for the surgery. The fluidics I generally use are pretty low. The IOP stays at 20, and that's across all grades of nuclei. I don't normally change my parameters based on the hardness of the nucleus. And the AFR also stays low at 23, and the vacuums at the 450 range. So we'll just sculpt out the softish epinucleus part that lies above the nucleus. Give it just a short twirl before we actually go ahead and chop the nucleus. So in cases like these, we're pretty soft and you can expect a lot of cheese wiring to happen. Can I get the dialer, please? So I'll just switch my chopper with a dialer, with a Sinsky, which is a lot blunter an instrument, because this cataract's pretty soft and the chopper I generally use is a pretty sharp one, so I just prefer to switch that with the blunter instrument. Somehow not been able to achieve a crack of the posterior plate, which is too soft to be chopped and too hard to be trenched. We'll just try to trench it a little bit very carefully at the center, so that we get a good division out in the center. Yeah. So at times they have to be levitated out of the bag when the nucleus is soft and it's not really cracking, and you don't achieve a clean chop all around. So that's exactly what I did here, levitating the nuclear pieces out of the bag and then emulsifying them. This is the epinucleus, which follows next. Saline on the cornea, please. Whatever little cortex is left. Okay, it's not coming out, it's a little stubborn, so we'll switch to IA now. So it's free of the nucleus and the epinuclear planes now. All that's left is a bit of cortex, and then we're good to go with the IL implantation. It's my routine practice to use a coaxial IA for the purpose, which makes it a little faster and The IOP, even in this step, remains at 22, which is not very high. But the vacuum that I use is 600 and it's in panel. So even without the support of the active sentry, which is not there in the IA handpiece, the IOP being at 22 with 600, the chamber stability is quite good. So we are good to go with the bag clean and ready to receive the implant. Now this is the assembly. I'll just show it to you. There's a 1, 2, 3 arrangement. This is the assembly in which it comes. Can I have visco, please? There's a tiny hole through which viscoelastic is pushed. This is the hole that receives the viscoelastic, and you can see, viscoelastic was given already. Then you release this lock. This is step number 2. This lock is released. Step number 3 is these 2 latches on the sides, which are advanced. They'll come to a click, and then the whole assembly can be disengaged from its holder. This is a preloaded platform. You can see the bifid plunger there, advancing the IOL smoothly onto the tip. That's where it stops. And then we go ahead and implant it into the bag. So we can see the rexus, we can see the whole bag. This is the aspiration cannula, sir. Give me the irrigation cannula. So this is the only step where the IOP increases slightly to 46, so that I have a good AC maintained while I go ahead and implant the IOL. This is a 19.5 geometric plus toric. The patient had just briefly stopped the irrigation while the plunger enters the eye, and then I restart it because there is a teardrop back cut, so it allows egress of fluid. I don't want that to happen. I just stop it briefly while the plunger goes in and comes out. No, the dialer, please, the Sensky hook. So the delta at the cornea was 2.29, which means the toric model that we would be requiring to correct that amount of astigmatism would be a T6. That's exactly what we are planning, a T6, and that's exactly what we have implanted. Now from the outset itself, you can see the diffractive zone, which is smaller than the IOL that you saw earlier in the last case. It's a 3.5 millimeter diffraction zone, and the angle at which it is implanted, it is to be aligned, is 179. I'm sure we are pretty close to it. Can we have the Callisto switched on, please? Okay, so it's not coming in the microscope. I'll have to look at the screen and align it. Oh, this is tricky. It's not coming in the microscope. Can I have the glasses then? 3D glasses, please. Yep, thank you. Yeah, we close. We are close. And we are bang on. Yeah, that does it. So, this has many features. We saw the implantation system. We have already heard about the material being very good. The textured haptics impart incredible stability, rotational stability to the IOL. And the other factor that is worth a discussion is the light distribution that varies according to the pupillary size. So, moxifloxacin, do you have it? No, okay, fine. So that concludes the case here. So we'll just remove the speculum and let the patient go. Thank you so much for watching. And if there are any questions now.
Thank you very much, doctor. There is any question from the audience?
So as I was just mentioning, the geometric family, the light distribution that it has is dependent on the pupillary size. So that actually governs which patient should receive what. Now in my practice, if I find the preoperative photopic pupil to be less than 3 millimeters, then geometric plus is a good option, because the geometric has a sweet spot of having 21% light transmitted towards near, At 3 millimeters pupillary size, if the pupillary size comes down or goes up, the light distribution for near actually reduces substantially, which doesn't happen with a plus. With a plus, if the pupillary size comes down, the light distribution is more for near. So if a patient has a preoperative photopic pupil, which is less than 3 millimeters, I would consider a geometric plus in at least one of the eyes, because the reading would be that much more easier. In converse to that, if the patient has a mesopic pupil less than 3 millimeters, then I would seriously consider a geometric in both eyes, because then the distance light distribution is close to 50%, and it just aids him in driving. So particularly if the patient is keen to drive in the night time, then, and the mesopic pupil is small, then I would go with geometric in both eyes. That's how I decide. Otherwise, if the patient's a female who would like to have low light reading, then geometric plus in one of the eyes does justice. That's how I decide. Thank you so much. As I switch to Dr. Samresh, who's the next surgeon. Thank you.